We're going to start the session on abdominal GI imaging. We are going to start with our first speaker, Professor Christine Mignaz. She's going to talk to us about targeted therapy effects in the abdomen.
Thank you to the Society, and I'm very, very thankful to be coming back to my home country. So I'm going to be talking about imaging findings of side effects of oncologic therapies in the abdomen. And my financial disclosures is I do have several books with Elsevier, and I am the current editor for Radiographics. So treatment paradigms in cancer are rapidly changing. We're seeing a very rapid change in therapies related to chemotherapy, targeted therapy, and immunotherapy. And these are the focus of this session. The advancement in cancer genomics, particularly precision medicine and personalized medicine, is key and has had a rapid change over the century, from the first targeted therapy of rituximab from the chronic lymphocytic leukemia to now over 100 FDA-approved targeted cancer therapies. It is these targeted therapies that have been targeted to the particular mutations of the cancers that has been precise, and it has been the FDA approval of over 100 medicines currently in our genome. So targeted therapies can result in adverse effects in either the targeted organs or off organs, meaning there's a wrong pathway or there's a wrong organ. And these adverse effects can be due to rapid tumor shrinkage, so you'll see hemorrhage or you'll see tumor bowel fistula. You can see a very vigorous blockade, so you sometimes see perforation or vascular occlusion. And then there is a self-attack, which we'll see with immunotherapy, including adrenalitis and sarcoid-like reaction. And understanding how these therapies work is crucial for the understanding of an expected treatment response, to understand what the adverse effects. So when you look at the literature, you will see a long list of the adverse effects in the abdominal cavity related to the targeted therapies. And it can be very, very problematic. We don't know how to start to memorize all these complications. But if you look a little bit more, you'll see that there is a common theme. Most of the adverse effects are related to bevacizumab or Avastin, or what we see tyrosine kinase inhibitors. So what we say, the MABs and the NIBs. So anything ending with a MAB or anything ending with a NIBs is something to be wary of causing many of these adverse effects. So how can we make this any simpler? Well, ask yourself when you're reading these patients, what the heck is going on? What is happening? It's really, if you understand the chart, I would ask you to look at what the patient is on currently for therapy. Is there any NIBs or any MABs? And you can see many of the weird complications that you may see in these therapies. So once you see that, you can guide and tell your oncologist, hey, maybe you need to stop therapy for a little bit to give a drug holiday to the patients. So we want to talk about specifically anti-angiogenic molecular target agents. These are agents that you have to know about. Many of our cancer patients are on vascular endothelial growth factor agents. Again, remember the NIBs and remember the MABs, particularly monoclonal antibody against this vascular endothelial growth factor, bevacizumab. This is one that you have to remember because many of our cancer patients are on this therapy. The more important thing is it is cytostatic, not cytotoxic. So the size remains the same, but the angiogenesis is decreased. And so the importance of these tumors, these treatments, is that they basically deprive the tumor of the blood supply that allows for the growth and the invasion of these cancers. So you're basically sucking the life of the tumors by giving these agents. And so what you can see is a decreased enhancement of these tumors. And because of this, because they work on the angiogenesis, they have increased vascular complications. You will see thrombosis. You will see pulmonary embolism. You will see GI perforation. You will see GI bleeding. You will see impaired lymphangiogenesis and impaired wound healing, which we'll talk about. Just to remember what happens with cancer, this is the normal tissue. It's organized. The tumor becomes unorganized. It's a haphazard. And these anti-angiogenic agents basically deprive that, prevent new blood vessel formation, prune the vessels, and disrupt the niche between the cancer and the stem. And so what you will see are patients with metastatic renal cell, for example, was on a tyrosine kinase inhibitor. You'll see the tumor that becomes anti-angiogenic, basically sucking the lifeline. The size remains many times the same, but the angiogenesis effect is real. Right, so sometimes you'll see some atypical responses. Pneumatosis is something we see very common in our cancer patients, particularly if you are in a big cancer center, you will see benign pneumatosis. Many of our patients are on dexamethasone steroids. Anyone with brain metastasis are on these. You will see what we call benign pneumatosis throughout the small bowel, particularly the colon. Bevacizumab is one that you want to remember, but you have to remember all the patients, almost all the NIBs, and bevacizumab, you could see the diffuse pneumatosis in these patients. So how do you differentiate pneumatosis from the ischemic version of pneumatosis? Well, it helps to differentiate the component of pneumatosis when you see that it's pretty. Oh, it's not even moving. All right, so pretty pneumatosis is a very pretty appearance to the bowel. It's not ischemic looking. There's no mesenteric edema. There's no mesenteric fluid. But one thing that you have to remember is that cysts may pop. And when the cysts pop, you will see free air. This is what happens with the benign pneumatosis. And this pneumatosis can last for many days or many weeks. So what do you do with those kind of patients? Here are patients, for example, that is on Herceptin for breast cancer and targeted therapies. You can see the pretty pneumatosis in this patient where there's no edema or stranding, and the surgeons did not believe us. 8 days later, we did an enema. You can see the benign pneumatosis doing nothing. The underlying colon is very normal. So benign pneumatosis is something you need to keep in mind in these targeted therapies. Here's a patient 8 days later, presenting every single day for x-ray, showing to see if the free air has gone away. It doesn't. It stays for a long time. This patient has free air at home, benign. This is something you have to remember in these patients with it. So 8 days later, still persistent with the diffuse pneumatosis and free air. All right, there is the pitfall. Remember, there is the thromboembolic complication that you see with these patients. And you want to remember particularly cisplatin, which many of our patients are on platinum-based therapies and are gemcitabine, like pancreas cancer. And don't forget your MABs, bevacizumab, and your tyrosine kinase inhibitor. For example, here's a patient with metastatic ovarian cancer. This is the first follow-up after therapy. You could see diffuse Mets and the IVC thrombus within the vessels. And what about this patient? This is a patient with testicular cancer. You could see the nodes in this patient. It's only 41 years old, coming with acute abdominal pain. What do you see? SMA thrombus, embolism here, diffuse ischemia in a 41-year-old patient. You have to think, what is the source? And this was indeed induced by his chemotherapy platinum-based agents. Something else you might see over time when you see follow-up patients, where you might see atherosclerotic change or vascular change around the abdominal aorta. This is only 1 month later, a pancreas cancer. This is aortitis. This is a vasculopathy that happens in the tyrosine kinase anti-VEGF type agents. Remember, you don't need to memorize it. It's one you want to think about, bevacizumab and N of your nibs. All right, one of the things that we do know about bevacizumab, it's an excellent drug. It's a fantastic drug on many cancers, colon, ovarian, glioblastomas, lots of our GI cancers are on bevacizumab. But again, it causes GI perforation. And why does it cause GI perforation? This is what we need to understand in these patients. Well, remember, VEGF deprives the blood supply of the tumor. No blood to the tumor. So what happens when you have a large rectal cancer? The large rectal cancer patients go under neoadjuvant therapy, shrinks the cancer. And when it shrinks the cancer, it can cause perforation. So when the primary tumor is in situ, it can certainly cause perforation from that. The other one, and more important one, is the serosal mets, particularly in your ovarian cancer patients, peritoneal mets. The serosal tumor decreases, but it perforates the underlying bowel and allows for perforation. So it's good news, the tumor is shrinking. It's bad news now that you have GI perforation. And the third thing that we need to remember, VEGF is an important agent in our wound healing. It's normal in wound healing. So you now give an agent to decrease wound healing. Anytime you have inflammation or surgery, it's going to take longer for that patient to heal. So you have a patient who had colon cancer. Colon cancer gets resected. 6 weeks after the surgery, oncologist starts bevacizumab. It wasn't enough time for this particular patient. The anastomosis breaks down. He needed more time for wound, and you have anastomotic dehiscence. This is one thing you want to remember. Our older patients have diverticulitis. They may be on Avastin. It takes a long time to heal, and diverticulitis lasts for a long time in these patients. All right, other things that you might see in these patients who are on NIBs is fluid retention. Their body starts to become heavy, their legs are burdened. You'll see third spacing. Here's a patient with a big gastrointestinal stromal tumor, and you could see that there's diffuse anosarca. And these patients just get put on a drug holiday, let them heal a little bit, and then they can be okay. Any of the NIBs or inhibitors can cause significant anosarca. Patients hate this. This is what they stop. Even if the tumor is decreased, they just can't deal with all this soft tissue, body wall, fluid overload. All right, another thing that you might see is lymphangiectasia. So it's very weird. The tyrosine kinase inhibitors inhibit lymphangiogenesis, which is needed for normal cell turnover. And so these patients present with diarrhea, significant diarrhea, protein losing. So if you look at their blood cell count, they're hypoproteinemic, they have low albumin, and sometimes you'll see the dilated lymphatics in the wall. So dilated, it looks like fat. It's not liposarcoma, it's not some weird, this is just the effect of the tyrosine kinase inhibitor, in particular pazopanib and imatinib, you can see with it. Look at the extent of the lymphangiectasia in this patient with metastatic renal cell carcinoma. Under targeted therapy, you could see the diffuse fat lobules within the wall of the colon. This is lymphangiectasia related to tyrosine kinase inhibitors. Other thing that you might see, it's very weird. You'll see patients who are on chronic lymphocytic leukemia who are on ibrutinib, particularly this drug. And all of a sudden, you start seeing macroscopic fat in the lymph nodes. Again, it's not liposarcoma. This is fatty replacement when the lymphatic tumor decreases, the central hilum fat gets bigger. So something that you see, it's a response to treatment on ibrutinib with our patients with chronic lymphocytic leukemia. Again, 3 patients showing macroscopic fat within the large lymph nodes. Another thing that happens in these patients, particularly if they're very large sarcomas that are on tyrosine kinase inhibitors, you can see over time that there is a decrease in the tumor. But what happens when it decreases, the tumor then is on the bowel wall and allows for fistula formation. Believe it or not, the patients stay on the medication because the tumor is decreasing as long as they don't have GI bleeding, as long as they don't have complications. They persist on the medication because their cancer is responding. Another thing that you might see is some fatty change within the liver, particularly in patients with irinotecan regimens, FOLFIRI, sulfoximib. You might see macroscopic fatty change within the liver parenchyma in these patients. We are familiar with many of the agents causing fatty liver. 5-FU or bevacizumab cause regular steatosis. The irinotecan is what we related to underlying inflammation to it. And this is what the surgeon calls the yellow liver. So they go to resect the liver for tumor. They may see a yellow or fatty liver. This is what happens after treatment with FOLFIRI or irinotecan agents. So what happens when they come to you for follow-up, particularly on CT? Everyone comes to CT for follow-up. You start seeing many metastatic implants. The liver now becomes fatty. Where did the implants go? You're not going to say it's gone because they can be hidden in this fatty liver. These are the patients that need to go to MRI. They need to get diffusion weight imaging. It's a very quick counting. You don't want to say the tumor has responded in the setting of fatty liver change on treatment. The sinusoidal obstruction syndrome is something you want to keep in mind. These are oxaliplatin regimens, FOLFOX and FOLFIRI. Many of our colon cancer patients, pancreas cancer patients are on oxaliplatin. You might end up seeing what it looks like: sinusoidal obstruction, hepatic venous congestion, a very mottled heterogeneous liver. This is what the surgeons call blue liver on operative. It really is dramatic on imaging. You might see new ascites, you might see a bigger spleen. This is not tumor expansion, tumor extension. This is just the oxaliplatin agent. This is one thing that needs to be discussed because the patient is taken off quickly from their agents. Let's talk about trastuzumab, Herceptin. It's a fantastic medicine on many of our GI cancers that are HER2 positive esophageal GE. We know our breast cancer patients are on it, but it is hepatotoxic to the liver. It is. We can't do anything about it. It is hepatotoxic. It allows, particularly if there's tumor in the liver, it allows, with its retraction and resolution, it retracts the capsule scars, and it relates into something what we call pseudocirrhosis. Pseudocirrhosis because there's not bands of true fibrotic bands on pathology. That's why it's pseudo, but it's not pseudo clinically. They have varices, they have ascites, they have GI bleeding in long-standing change. So here, for example, is a patient 3 months post Herceptin, and you could see the changes in the fibrotic nature of the liver. All right, so let's just look at one case here. I will show you how subtle this is. Here's a patient who has very small metastatic implants in the liver with a patient with breast cancer on trastuzumab, for example. You could see 2 months, maybe your eye will change with the capsular scarring. Certainly on 4 months, you could see that there is some scarring, capsular change. And 12 months after therapy, there is definite pseudocirrhosis, and you could see there's gastropathy and varices on endoscopy. All right, other hepatotoxicity that you want to think about, again, any of the NIBs can do this. It can cause biliary strictures, what we call secondary sclerosing cholangitis in these patients, portal vein thrombosis, which we just talked about, bevacizumab and our NIBs, and in our autoimmune pathologies. Okay, quickly at the end here, we're going to just touch on immunotherapies. Before 2011, immunotherapy was considered very, very bad, had a lot of toxicity, killed our patients. And you could see over time, it's basically one of the best advancement of treatment algorithms out there. It's got the Nobel Prize in 2018, and it's now first line or second line therapies on almost every cancer is on immunotherapy. And so right now we need to understand what is the changes that we see by imaging and what are the complications. Now, I just want to, we're not going to go into the basics of the molecular, but something very simple to remember. Immunotherapy differs than chemo because immunotherapy affects and hits our immune system. It revs up our immune system. It makes our T cells go crazy to attack the tumor. So it activates the T cells to attack the tumor, not attack the tumor itself. And because of that, it attacks the host, so it'll attack us as well. And so there is a balance between the self-attacks of the adverse effects and what the tumor, what the targeted immuno is doing it. So the oncologist knows the patient has a big hypertensive, starts having a rash. He knows that the targeted therapy is working. He's going to start he's going to continue that immunotherapy because he knows that these adverse effects work. It's a whole list of adverse effects related to immunotherapy. They have a big reaction, a rash. There's a sarcoid reaction with lymph nodes, myositis, myopathy, and the diarrhea, and of course, we know with the organizing pneumonia at the lung basis. It is something that represents that there is survival benefits in these patients. And the toxicities differ in severity. So the early ipilimumab, you could see that they are, diarrhea, the rash, and hormonal changes are more severe and dose-dependent. When we move on to Pembro and Nivo, they occur later. They're not as severe and not dose-dependent, meaning just because you decrease the dose doesn't mean the adverse effects go away. And many of our patients are on combined therapies. They want to kill that tumor. And so you'll see a lot of patients with significant side effects from these. But it's a great finding for oncologists. These patients are managed by steroids. It's a sign that the patient is responding to immunotherapy if the body starts to self-attack. So we see, patients who come in with diarrhea, the colon is fluid-filled. Almost all of the immunotherapies cause diarrhea-related immunotherapy, associated colitis. These patients are taken to endoscopy. They grade them by colonoscopy. Again, they're typically given steroid therapy. Some of them are given some immunomodulator to help their therapy. They're kept on their treatment, but they're given steroids to decrease the self-attack of diarrhea. Here's a patient, maybe it's not that bad to you, fluid-filled, mild mucosal enhancement. Again, it's a grade 3 colitis on endoscopy, resolves on steroid therapy. Again, the cancer is working, is responding to the immunotherapy. Other things that you might see that's very weird, the adrenal glands will start. Here's a patient who was who's metastatic melanoma, was put on IPI. You could start seeing the adrenal glands getting bigger. There's diffusion restriction. That's not going to be a tumor that's developing in 3 months. The patient is taken off, and you could see the decrease in size. This actually does not ever come back. There are hormonal problems with the hypophysitis that happens is something that remains in these patients. Last thing we're going to just talk about is what happens when the patients are on immunotherapy. The tumor gets bigger. Why? The T cells are attacking the tumor, and all of a sudden you start seeing the tumor getting bigger. This is one thing that you want to remember. It's about 15% of our patients. You will see an increase in size in these tumors, or even new tumors that develop under the immunotherapy. This is something what we call a pseudo response, a pseudo growth. You could see either you get growth of tumor or even new. The patient is kept on immunotherapy according to the protocol, and then you could see decrease in the tumor and decrease the tumor and the new lesions. Okay, so in about 15% of our melanoma patients are having pseudo-progression in these immunotherapy. So we will see patients that have lymph nodes, they have immunotherapy. You can see even the infiltration around it. That's the inflammation around the tumor. That's not increase. That's not progression. You just want to give the size. Do not talk about progression. Do not talk about needs to get off. That's the oncologist's job. 4 to 8 weeks later, you could see that there is a decrease in size. Another thing that you might see, it's very scary. You see a patient, metastatic renal cell, it's pancreatic mass, follow-up, diffuse peritoneal implants. First follow-up, diffuse peritoneal implants. Kept on immunotherapy, you could see what happens over time, decrease, and that's the pseudoprogression that you may see on these patients. After saying that, there's lots of therapy, lots of papers out there for that. Just know that something that you have to keep in mind, it's best not to call pseudoprogression, not best to call progression, it's just called increase or decrease. So our oncologists are calling it unconfirmed progressive disease on the first follow-up, and then if stable, they are kept on. If they continue going up, then it's called confirmed progressive disease. So here's a baseline patient. On the follow-up, it's getting bigger, and you can see this is 4 to 8 weeks. It's confirmed progressive disease. This is somebody who's going to be off immunotherapy. Just to end, the hyperprogressive disease is a real thing. There are patients, we don't understand why, but they all of a sudden get revved up with immunotherapy and get very, very bad after the 2 therapies. You could see, for example, baseline metastatic melanoma gets bigger on the first scan and much bigger and hyperenhancing the second scan. This is hyperprogression on it. So in conclusion, widespread use of targeted therapies, unique profiles, should not be mistaken for tumor progression, understanding what they look like, and it's important to look up what therapy is on this patient, and keep pressing forward. Imagine where we're going to be 20 years from now. It's only going to continue to progress. And I'm sorry I went over.
Thank you, Professor Christine, for an illustrative presentation. First, any question on the floor? I would like...
Thank you very much, Professor Manias, for the excellent presentation. You have mentioned a lot of complications for the targeted therapies for oncology, and I'm also interested how often did you see targeted therapy induced autoimmune pancreatitis in your institute?
Immunotherapy related pancreatitis.
Like anti-PD-1 drug, like nivolumab in melanoma patients.
Right.
Yeah.
So how often? I don't know a denominator, but I've seen it several times where the pancreas looks like autoimmune IgG4 type appearance. They get taken off and it fibroses down and decreases. Autoimmune pancreatitis, autoimmune cholecystitis, biliary strictures, liver disease on immunotherapy. Many of the patients now are these complicated regimens where at Mayo Clinic, they try everything, first line, second line, third line. Some of them are on 2 immunotherapies plus platinum-based agents, so they're getting the full. So we do see some very odd type complications. It's not uncommon.
I would like to ask a question, Professor Manias, is that using target therapy with treatment of cancers, there's always a price that you have to pay, and this price is all the side effects. And we have seen oncologists stop the treatment because of the side effects, and then return back to the treatment, and the side effects are partially relieved. But there is no specific protocol or criteria for this guidelines, or when to stop or when to continue, especially in complications like in fistulas and strictures and abscesses and things like that.
So it depends on how aggressive the oncologists are. And it depends on, it's definitely personalized. A patient can say, I cannot handle my legs being too heavy. It's very heavy. They're on water pill, Lasix. The oncologist will say, stay on the medicine, it's working. He's like, no, I can't tolerate it. So it's very patient-centered, personalized. I'm very much an advocate of aggressive therapy. My dad had pancreatic cancer. I'm very sympathetic for treatment and aggressive therapy in patients. I've seen wonderful things, not only are bad things, and so if they can handle the side effects, the oncologist usually stays on it. The ones that scare you are the fistulas. You see it in the bowel, you see it in the lumen, and they are on the therapies, and they do fine.
They do fine.
They do fine,
Very
as long as they don't GI bleed, because the tumor is decreasing. It's just hanging out in the bowel. I mean, they sometimes have diarrhea and things like that. But
And do they sometimes need intervention? Do they reach the extent of needing for intervention, like resection?
oh, sure, if there's bleeding, sure, interventional can easily go and try to, gel foam them, decrease that blood flow. I mean, the beauty of multidisciplinary action is, try to keep that patient alive.
This was my second point, is that I think the best results would come from MDTs in these cases, of course.
So I come from a cancer center, right? So we have MDTs for almost everything. But the bigger ones, we have it for colon cancer, pancreas cancer. We don't have it for lymphoma, for example. We don't have it for, testicular cancer. But we have a urology conference. We talk about the therapies. There are some people who say stop the medicine. And I say continue, because it's free. It's a protocol-based, very expensive agents for our cancer patients. Keep them on one more time. Let them try before you take them off. So I think it's important.
Thank you very much.
Thank you.
Unfortunately, our second speaker, Professor